I'll play catch up with you later.
Okay.
All right, now here's the deal. I said, let's do this in the afternoon tomorrow. So they said, nah, I guess I'm going to draw 2 people away. So I said, all right, I'll just pull out something. But the question was raised, and you have these two folks to thank for raising the question, are we going to get credit for this? Yes, you are. So if somebody has a piece of paper, you write your, or just say, look, I will give a password, I'll give a code word. You have to have the code word to get the credit. Okay?
There you go. But you have to know how to spell it.
All right. Did you hear all the references to what happened in the text? Right? What do we used to do? This is going to be. There is a TV.
Why can't all classes be like this?
Well, so much. Oh, all right. All right.
I'll get another one. The only one.
How about you?
Okay, well, I got a whole stash in the back. So one more, two.
Who's been in EMS for 10 years? 15 years. 20 years.
Just hit it. Just hit it.
25 years.
Keep going, Wayne.
30 years. 35. Who got their AARP card from the EMS Commission? All right. This is my take on EMS, where we came from, where we're going, what we did, and why we did it. More importantly, the research that supported what we did. All right, so. Oh, this was fun. Those are all my patches. They all have Velcro on the back. Because I would go from one job to another. We do that.
Amen, brother.
All right. The longer you stay in the business, the more initials you get after your name. When you have more initials after your name than in your name, stop. You've done enough.
If you're giving it for free, I won't say no.
All right, so
I'm joking. No, sorry, I'm good.
80s to today. We'll talk about education. We'll talk about scope of practice. We'll talk about current and future trends in EMS. All right, yeah, Ghostbusters.
Yeah.
Well, actually, in the beginning, those of us who squeak when we walk, we actually probably were turned on to EMS by this show, Emergency. Why?
It was cool.
Okay, look, I'm traveling out that, you know what? I'm finding out a lot of things I did in my younger years is now cool. EMS is cool. Singing in the choir in high school is cool. Well, it's cool now. Or at least they have better lives than I ever did. But we all felt, I did it. I love Dixie. This guy's still on the talking circuit. This guy, I couldn't grow sideburns like that if I tried. She actually was married to this guy. Wow. All right. So, really, in the beginning, think about it. Back in the 80s, patients are the same as they are today. Now, it's bad when the patient is younger than I am, but a 50-year-old guy who's got the visceral chest pain goes to his left arm, he's sweating nauseated, overweight, he's a smoker, he's got the trifecta, hypertension, diabetes, and cholesterol. Okay, you know that he needs to go in because he's like a time bomb. What does he say to you? It's just gas, I'll be fine. Yeah, what we were taught is, don't talk to this guy, he's an idiot. Talk to his girlfriend, talk to his wife, says, you know what, he's probably having a big one. And if he has the big one, he may become a cardiac cripple, so he won't be able to do anything. You'll be wiping his butt as he just lounges around here. She will carry him to your ambulance for you. No, not yet.
There you go.
Hey, all right. Yep. Weren't they the most comfortable vehicles to run a code in? Put your back against the ceiling and do your compressions. Well, actually, that's where I started. I started in Newtown Township Fire Department. That's out of that month where those people go to run the horses. Yeah, well, we didn't go with them. We were out in the fields. They were out in the back of their Range Rovers sipping champagne and eating strawberries. But in the beginning, we used to have a lot of fun. How could you tell how many providers were on scene? How many helmets were on the top of the car? Until you got the windfall. All right, hey, look at that. We used to do standing backboards and torture people with waterboarding. That is not our summer uniform. uniforms. That's from my honeymoon in Hawaii. Although, how much different is it carrying a patient? Really not much different than them serving dinner. So I want to look at a couple things that we did with some of the time-sensitive diseases and where we're going and what we're doing now. So back in the 80s, what do we do for folks who are having a problem with their heart? What do they get dispatched as? Medical, a coronary, heart problems. They didn't give you anything for information. Okay, we put them on oxygen. We had a monitor that had the lead tube. Woohoo. Put an IV in them, D5W, at TKO. Why? Because we love acronyms. I love acronyms. TKO, keep vein open. All right, that's fine, because that was for hearts. D5W was for hearts at TKO. You gave him a nitroglycerin. You called medical command because you had to give him another nitroglycerin because the first one didn't work for you. And shit, good luck. You took him to the closest hospital. How many remember Haverford Hospital in Delaware County? How many remember having to ring the doorbell to get into the emergency department at Haverford Hospital? Okay, yeah, there we are. Rings like the good old days. All right, so what do we do? Back in the 80s, with regard to cardiac care, hospital care was not a priority. Now, there were some crazy radical units out there that thought, you know what? When we're not out on a call, they force us to do things in the hospital. They make us work. And we said, well, you know what? When we're in the pre-admission testing lab, they make us do 12-lead EKGs. And what they do is we put little suction cups on and makes little hickeys all over their chest. And we have to move the lead around, because all we're doing is changing the angle that we're reading electricity. Okay, fine. So why can't we do that with our monitor? So we took a LifePak 5, and we took an APGAR, and we stretched our arms, we walked out into the field, we put the monitor leads on, and we moved the monitor leads around the chest and sent a 12-lead in the 80s to prove it could be done. Because those crazy idiots at Medic 92 and Medic 109 at Bryn Mawr, the startup unit, yep, I was there. I was one of the startup makes at Medic 109. I was also the first full-timer to leave Medic 109 for what happened. Because that's what we use. Now, I learned today something new, is that if you had a green screen on your LifePak 5, you could do synchronized cardioversion. If you had a blue screen, you couldn't do synchronized cardioversion. But it was nice because, you know what? Patients are heavy. The litter's heavy. There's no such thing as burp, burp. Oh no, you carry it. And if you want to decrease some of the weight, see those things on the right-hand side? Well, you can detach that side. You leave the paddles behind. You don't need that. Just take them on. That's all you need. When did the patient code? Just as you're coming through the door. Where's your paddles? Back in the truck. How do I know that? Don't ask. Statute of limitations has run out. Let's bring back memories. All right, so but realize back in the 80s, 12-lead EKGs were not the scope of practice of paramedics. All right, so back in EMS. All right, there's Dave Pettit. There's guys at Haverford. There's Nick Campbell. Oh, no. And Mark Ragnone. Okay, Mark was one of my partners down at Delco. And good alcohol back, another one of my partners at Delco. Yes, look, we don't get out of this job, please. But that's us back in the 80s. What do we do with the dead people back in the 80s? We transported everybody, we worked everybody, and it really didn't matter how dead they were. Because what did we have in the back of the squad? We had that demonic device that you had to check your M tag and see how much was in it. Okay, yeah, I can put the thumper on them, and you had this piston go. No, this is not the tennis health benefits of what we talked about earlier. This is a demonic device depression. We started off with 2 layers of bicarbonate calcium. Now, any chemist in the room would say, well, that's going to be, that's going to precipitate calcium. Yes, we made chalk in their veins. I think people lived in spite of what we did to them. But we did CPR, and we did it with people, and we did it with thumpers if we had enough oxygen, because we didn't have enough oxygen. Oh, well, I don't feel like sweeping that M tank to the back of the station after I change it. Was that a member of the Edgemont Fire Department, and the state came in and said, you have a device on your fire truck that is illegal. Get that AED off the fire truck. You're firefighters. You cannot use that device. They threatened to shut down Edgemont Fire Company because we had an AED on one of the trucks. Now also, I came through the program at Delaware County Community College. Had a great time there. When we hit the streets, we weren't certified to intubate. You went to your squad, and they taught you how to intubate according to how your squad teaches you to intubate. So it's great. But if you're not certified, you got a problem. So they sent me out one day as an aid car. I'm not certified. I'm the new guy on the block. So I asked my supervisor, well, what do I do? They will call the other unit for a tube assist. Oh, yeah, that sounds good. So I get dispatched to a cardiac arrest. Back then, what do? If you're alone, you're going to secure the airway. Supervisor shows up because they heard it's a cardiac arrest. It hurts me. They know I'm not certified to intubate. They know I need help. And they walk in the door and go, who intubated the patient? I looked at him. It was amazing. The clouds parted from above. Huge man tossed, and he landed right in their trachea. What do you think? Field promotion, you can intubate. But wasn't it a very enjoyable time? Who remembers driving to a reported cardiac arrest and singing the song? Start your day.
DOA, doo-dah, doo-dah.
Oh yeah, we did it. We are not proud that we did that, but it was a good time. Now, where do we learn the research that supported what we did for the dead people? Because we knew CPR was the most important. Well, we actually gleaned that information from the two agencies that basically fought to teach you CPR. American Heart Association and American Red Cross. Now, if you were a Red Cross instructor, you could not teach for the Heart Association, vice versa, because, oh no, they teach different than we do. How many of you argued with the person who was your CPR instructor when they're saying you're not pushing deep enough, you're not pushing fast enough, and you asked them the question, how many people have you put your hands on and actually done CPR? And got the answer of 0. They could teach you, but they couldn't treat them. The bottom line we learned was bump and blow. We learned that from dogs. From the fun time of learning how to resuscitate dogs, it's like playing an accordion. I'm Polish, it's in my blood, I can do it. But we applied the dog model to humans. Now back then we also had lethal rhythms that had cool names. EMD was everybody must die. They changed it to PEA. I don't have a cool name for that. But back then, EMD, we knew they were going to die. Then we had some other radical units that were out there, and we were using these hollow metal needles that they could re-sterilize to start our IVs. But we also had to hang an IV on everybody who we started on. And you clipped it on the roof of the ambulance inside so that when you took the stretcher out, what happened to your IV? Right, it came out. So there was this bunch of people saying, I don't want to restart an IV. So we're up on the floors starting IVs for the nurses who never tried to start their IVs. They would just call the medics. And we said, why don't we do that? And there was also another reason. Who remembers their 747 plane up? Who remembers having to carry a datascope just to balance out the weight because you had 6 liters of fluid in there? What were your arms like at the end of the shift? You looked like a gorilla dragging your knuckles. Or one of my relatives. We won't talk about that. All right, so we actually said if we don't have to carry as much IV fluid, then maybe we can not feel so bad at the end of our shift. All right, how about strokes? What did we do with brains back in the 80s? Oh, I had that oxygen stuff because I didn't strip the M-tank putting the thumper on the last patient. So we put them on the monitor. Okay, there's our V2. Oh, no, we've moved a couple of years, so now we have a LifePak 5, so I might go and flip that around a little bit. But now we put some D5W into them, but this is the brain. So it's not TKO, because that's heart. Now it's KVO, keep vein open. Different acronym, different part of the body. You started to see scattered AccuChecks. Now this was because we had those nice little gel codes that you pull out and you could kind of pump the back of the hollow needle and get a drop of blood to come onto it. And then you waited, and then you wiped it off with a 4x4, and then you had somebody shine a flashlight over your shoulder while you looked at the bottles. Well, does that look like 80 or 300? And then you drove the stroke to the hospital. Now, in some areas of the Commonwealth, it was BLS dispatch for stroke because the thought was, what would a paramedic do for a stroke anyway? So you did a slow transport to the ER, you did go through the waiting to pick up your lunch, you went before. Oh, the person had the stroke 2 days before. It was okay. Statute of limitations has run out. You wrote your charts in the back of the ambulance because what were you doing for the patient? Honestly, we were doing nothing, so they weren't that far off. And what were our radio reports with the strokes back then? Be there in 5, be there in 10. It was truly just an ETA. All right, so, let's see, who we got up there? Dr. Singh, actually first guy who went into, back when he had black hair. Okay. Jerry McGinnis, my boss, Joyce Forden, and Gary Bates, the guy who, one of the guys, there were 3 of us that worked at Springfield. We kind of vied for the 1, 2, 3 slot in paramedic school. Yep. All right, there we are at Haverford. Why did we have an A-frame ladder at Haverford for our medic unit? Don't ask. But we had it. It was cool. Look at us. Big hair, big aviator glasses. Oh, you hear Staying Alive playing in the background, don't you? But that's us. We had a great time. That's some of the other units out in River Creek State Park. And everybody just hanging out, having a great time. You know what? We're proud of your units. You come out and show your units. I asked for some units. I needed a photo. I got a whole bunch coming out there. Fitz's unit was out there too. They sent the little Jeep. Remember that little Jeep that you sat in it, and anybody who was normal size like us were hitting shoulders? All right, back in the 80s, I was the first class to go through where they didn't give you the choice of going up to paramedic 1 and then continuing on to paramedic 2. Because, you got your P2 rocker after you completed some extra training. But you could be a P1 and still function in the Commonwealth. Well, P1 was 115 hours. P2 was another 84 hours. That means I'd go back to work, back to school, but I could continue working and still make the same money as that P2 guy. Why would I do that? Well, I'd have to learn about geriatrics, pediatrics, orthopedics, and OBGYN. So as long as I don't have an 80-year-old who broke her hip and is giving birth, I'm fine. You had to pass with 80%. You got 500 clinical hours, field and in a hospital. You had 5 books stacked up to that. That's one. But like I said, you had no requirement to become a P2. But back then we trained people to do really cool things. We shoved DOAs and GTAs into people. Oh, great acronyms. What's that? Esophageal operator airway, esophageal gastric tube airway. Both had looked like a demonic tube with a face mask attached to it. One had a hole in it, so you could put a nasogastric tube through it to decompress the stomach. Was trained to do rotating tourniquets and phlebotomy for congestive heart failure. There's too much fluid in the body. Get the fluid out. What do you have available to you to get the fluid out? Drain them. Hey, killed George Washington, but don't worry about that. Again, we use the winged, hollow, re-sterilizable needles to start some IVs, especially in kids. Scalp veins. But we also did central lines. Did internal jugulars, did subclavians. For those of you who work in departments, after the intern gets that subclavian, because it's the first one they've ever done in their life, and the ultrasound machine is being used somewhere else, when they call it, give me a chest x-ray. I don't know how many lungs I dropped. But we did them because we had this sword, this 10-gauge sword, stuffed in my whacker pack on the side. It was cracked, it was crumbly, it was dirty, but I had that. I could, yeah. Trust me, it was safer to use it to spike a watermelon with vodka than it was to put it. So we're moving later in the days, but we're still not certified to intubate. Now, national registry was optional. For those of us who worked at Haverford or Crozier Medical Center, you had to get the Michael Jackson patch because it was shiny satin. It was really cool. And if you work at one of those places, you could put, well, let's see, Haverford gave you 2 Haverford patches, Haverford Township patches. They didn't let anybody know that you were a paramedic. Crozier had the Michael Jackson patch. All right, so let's jump through. Oh, that's ugly color. What do we do with the hearts in the 90s? Let's get into the 90s and think what we did. So we put oxygen on people, we have pulse oximetry, because now we want to know a little bit more about the people. You start seeing in the 90s that 12 leads are starting to make their presence known. And folks are doing pre-hospital 12 leads. Well, if you're doing them, that means somebody's teaching you to recognize what you're dealing with. You start seeing sailing locks, because there was this crazy, crazy medical director who said, this is stupid that you're starting lines on people and you're giving them 2 teaspoons of saline. Why don't you just start a saline block on them, and then if you need to do fluids, you can always attach into it. What did it do? It saved money. It was a cheap research project. Got it through. Pretty much, if you're active today, are you thinking about putting a line, putting a KVO bag of saline up? Just starting a saline lock. It's easy. Nitroglycerin bumped up to repeat doses. Why are we delaying the ultimate care for the patient? Now, morphine was still one of those things you needed the stars to align. Dr. Gordon shouldn't be anywhere near the radio. So you still had to pay and clean. But you started towards the end of the 90s seeing very progressive systems, and they were mentioned tonight. Lehigh Valley Hospital had a protocol for if you recognize an inferior wall MI, you do not give nitrates, you give morphine. They were progressive. You still, though, just took the patient to the closest hospital, whichever was their choice. Take me. Now, you also started to see the research following up and saying why we did what we did to these patients. These were when the TIMI trials were coming out. And what they found, and this is what drives door-to-device time with cardiac care, is that if you could restore normal flow in 90 minutes or less, the patients did better. So TIMI free flow was normal flow in 90 minutes. The American Heart Association got into acronyms too, and they came up with MONA. No, that was not somebody who was up for a good date. That was morphine, oxygen, nitroglycerin, and aspirin. Oh. Not. Ooh, this is bad. I can beat you. All right, now you also started seeing some preferential transport to cardiac centers. Now, the dead people. We kind of changed our process with dead people because we figured, okay, they're dead. There's nothing happening. There's no flow. So no oxygen is going to the tissues to keep everything going. So if we could hyperoxygenate them and get the oxygen levels back up, that would be great because we could provide the substrate, the energy for the tissues to come back online so we could resuscitate these people. So we intubated them and we hyperventilated them because this was a theory of oxygen debt that was being promoted. CPR at that time became a courtesy more than a priority. Unfortunately, that courtesy kind of persists, and I guarantee you that any department in the area, you'll see this. Somebody walking alongside and doing the compression. That has not gone away. Generally, it's who's going to be voluntold to get up on the litter with the patient, and they're going to ride the litter in. Yep. Yeah. Generally in EMS, if you need something done, you find the smallest, most highly qualified person. So Andy's a great to give you a corollary to that, when I was at Newtown Township, or Newtown Square Fire Company, they said, okay, well, what we do is when we have somebody trapped in a vehicle, we're going to make a hole and send the smallest, most qualified person in. Well, it's like, well, I'm the paramedic. So you're going to have to take the freaking roof off to get me in there, because making a little hole isn't going to work. I'm a normal-sized person. So CPR changed. Now, this is also when we look at epinephrine and showing how epinephrine in repeat elevating doses increased the mean arterial pressure. Increasing the mean arterial pressure in a cardiac arrest, and this is derived from pig data, we've moved on to a different species, you had a better outcome. So you had epinephrine, and epi was a good thing. We loved epi, and it was escalating doses of epi, to the point where you started off with 1, and then you gave 3, and then you gave 5, and you gave 5 more. And I have a chart from, it may have been your chart, Kurt, because it's Western Berg's chart. They went through 2 30-milligram multi-dose vials of epinephrine on the code. Great, lots of epi. So we catecholamine whipped these people back to life. We had stacked shocks. What was the theory? The first shock made slight inroads in through the chest. Second one followed a little further. The third one got to myocardium. That was what was promoted. Sounds interesting. Might have even worked. Okay, we looked and said, our problem is we can't get the medication into people. We got 2 because we're intubating them and hyperventilating them. Well, guess what? The lungs have the surface area of a tennis court. Why don't we just spray the medicine into the lungs? So we did that. We shoved things down the T2. And we did have acronyms for that. ONABLE, oxygen, narcan, atropine, Valium, epinephrine, lidocaine. Doesn't mean that calcium didn't go down there, glucose didn't go down there, glycol didn't go down there, Chilin didn't go down there. Chilin didn't save anybody's life.
Except ETs.
Oh, gosh. Now, external pacing was kind of a command-only thing. Because you sat there, you scratch your head, and you think, well, Al, do you have any more ideas? No. You have any more ideas? You want to call command? All right. I'll go out to the truck, I'll call them. Yeah, they said put the pacer on. What are you doing? You're pacing a stone by that time. So unfortunately, a device that has been shown to be effective was so far down, it didn't help us. All right, now, so in the 90s, we realized that the outcome was, it's the same. And, there we go. Nope. Yep, there, all right. So now, on comes some emergency medicine research. And we looked at it and we said, okay, we got to look at poor outcomes, especially for cardiac arrest. Because people are dying, and despite what we're doing to them, we're really not improving. It's great to hear we've improved the survival rate in the Commonwealth by 70%. But we looked at it and said, well, what are some of the things that lead to poor outcomes in cardiac arrest? And one of them was missed esophageal intubations, poor IV access, and said, well, and these medicines, do they do what they say they do? So we called into question some of the good old medicines, lidocaine, beryllium, bicarb, calcium, and epi. And if you look at it, epi, in super high doses, yes, we got a heart back because your catecholamine, as soon as you took catecholamines away, it's gone. Calcium was a case study of a hyperkalemic cardiac arrest, and what they said was, wow, we squirted some calcium, look at that, the heart came back. Bicarb, we actually proved that if you give bicarb, you improve the intravenous pH, but you worsen the intracellular pH. And since cells love to work in a very narrow pH range, you made their working environment worse. So you have poorer outcomes. Again, beryllium never saved anybody. If they had a shred of life in them and made them vomit, that's about it. All right. So lidocaine was then called into question, went up against amiodarone, now we swung back the other way, they said you can pick either one. What do we do for strokes in the 90s? Okay, did the oxygen monitor, AccuCheck. Now you're starting to see numeric AccuCheck, so you actually get a number of glucose. So those of us who feign ignorance or at least color blindness, because I think this felt blue this morning when I got dressed. Okay, so they're tan. But you had a number that you knew what you were treating. And you did IV access on these folks. You're starting to see emergence of the Cincinnati Stroke Scale because we're looking for ways to say this person is probably having a stroke. And what we found by doing a very simple test is you could improve your predictive value of evaluating your patient and saying, yes, this one's having a stroke, or maybe this one is not having a stroke. But it's not in the hospital that we're doing it. We're doing pre-hospital. You start to see folks running down on the list saying, you know what? This person has not had a stroke in the past 3 months, has not had a major trauma, is not on a blood thinner, has no history of low platelet count, and ran essentially a thrombolytic screen for us. Because Dr. McCann remembers that because she was the one that looked at this region as to how well we did with strokes pre-hospital. I believe abysmal was your first evaluation, and it improved from there. Now, you also saw places holding themselves out as stroke centers, and you started to see preferential transport to stroke centers. So because a lot of the data also showed if you go to a hospital that does procedure X 100 times a year, you'll do all right. You go to another hospital that does procedure X 1,000 times a year, they're going to do better. So you start seeing the preferential movement to hospitals that specialize. You also started to see helicopters utilized for something other than trauma. You want to really, in the 90s, if you want to make an emergency physician's head spin, tell them that there's a stroke or an MI coming in by helicopter. What? They're not shot. They're not run over by a truck. They're not stabbed. Why are they coming in by helicopter? But you start to see that. Now, the American Heart Association also realized that the disease process that causes stroke is the same that causes coronary disease, so why not get involved in it? And they were trying, they had Mona. People know what a heart attack is, but there's nothing to really make, the stroke a sexy disease process. So what they did was they sat us in a room and they said, let's come up with an idea for a name. And They took a lot of suggestions. They didn't like my suggestion. All right, so, but what are we doing with education for advanced providers? Well, we've already changed it so you had to complete all modules. You were coming out the other end as a fully trained paramedic. We added more clinical hours, more didactic hours, so you're sitting on your butt more, you're getting more DQs. You added more clinical hours. You were allowed to be abused by nurses more. The nurses were allowed to pick on paramedic students. Preceptors were allowed to pick on their preceptees for 300 extra hours. So we're saying, what we realize is there's more information for you to learn, but you don't have enough time to learn it, so we're going to extend it out. Pennsylvania gets out of testing. It's no longer Pennsylvania issuing the test now. All testing is National Registry. Now you got 3 tries to pass that, and oh yeah, then you showed up at some cool place where they're coding that person, but nobody's on the chest. They're really, they got prettier in the 90s in the emergency department. All right, now what's happening today, or relatively recently today? Now, I got a question for you. That's a brand new ambulance. If you were selling a brand new ambulance, would you have a cockeyed license plate holder on it? I see the same world you do, I just see it a little off. Dubuque, Iowa, they have huge people in Dubuque. Look at those things. I've seen smaller motorhomes. Sweden, and I was like, hey, what are we going to do with a Saab? It's cut in half and add a camper. So, let's look at heart today. We give them oxygen. But now we're also receiving our 12 leads faxed to the receiving, they're coming to the receiving facility. Morphine is in the protocols, again, especially with the inferior wall MIs. We were seeing thrombolytics given pre-hospital in certain areas that had long times to get to the cath lab. So in Norfolk, Virginia, the flight crews were thrombolysing from the Outer Banks as they're bringing them back to the cath labs. In rural metro down in Dade County, they were having such a time getting to the cath lab. Once you got into the emergency department, medical students saw the patient, they went and reported to the intern reported to the resident reported to W resident, then called the fellow said, I'll be in. And by the time they got there, the person was either dead or they recannulated themselves. So what they found was it was actually quicker in some of those areas, and they proved that EMS can give thrombolytics pre-hospital. Now, you also started to see protocols coming up to say, this hospital can take a patient to the cath lab. They have the ability of opening a cath lab 24/7, and this one can only do diagnostic. You need to protect yourself and do the best care for your patients. You can bypass this hospital and go to the other. Again, more hospital transports from out of outlying regions, taking the time-sensitive diseases and shortening the transport time to get them to definitive care. You had STEMI alerts. You had paramedics interpreting the 12 lead, calling in, saying, I got a STEMI. Who would thunk it? Now, what are we doing with the dead today? Now, with the dead, well, they're still dead, but we're making a decision that, depending on a couple things, we're either going to stay and play, or we're going to feel terminated. And, again, the primary treatment depends on your downtime. So, if you're there within 4 minutes, and whoever gets on scene within 4 minutes, okay? If it's less than 4 minutes, you do electrical therapy first. If it's longer than 4 minutes, CPR for a couple minutes, get into the system, start circulating, move things along, and then electricity. We got out of the pump, okay, breath, pump, breath. Because what we showed is that as we're doing compressions, we're building our mean arterial pressure and we're getting to a plateau, but as soon as we stop to give that breath, mean arterial pressure dumps. And they showed increased survival when you maintained an elevated mean arterial pressure. So after about 20 minutes or 2 rounds, we figured out, guess what? Do you bring any magic to the pre-hospital cardiac arrest that we don't have in the emergency department with the majority of cardiac arrest? So we just said, stop. It's been 2 rounds. It's been 20 minutes. Do you get anything? No. We give some parameters. And the other thing we looked at is that when you have the cardiac arrest patient, they're in a hypometabolic state. They don't have the oxygen demands. And what we also found is that hyperoxygenating these people lead to certain byproducts, oxygen-free radicals, that are actually more detrimental to the neurotissue. So you have a worsened outcome when you have the hyperoxygenated patient. So now it's hypoventilation with oxygenation, but not hyperoxygenation. We've got entitled CO2 monitoring interpretation. What does it mean? It means it tells me if I have any metabolic function going on. More importantly, it tells me if everything I'm doing is not leading to the return of spontaneous circulation. You know, because how many folks have seen a code recently where it's okay, charging, everybody off, you're clear, I'm clear, everybody. Shock, check for pulse. Who's seen that recently? Great, it's gone. All right, but how many of you are starting to see that, you know, you get the idea, and they're like, oh wow, I'm going along and get this lousy end-tidal CO2 number, and all of a sudden I get a spike. How does that feel when you know metabolic function has just come back online, and what you're doing is making a difference with that patient? And you're interpreting that data. Biphasic defibrillators came in, they've kind of gone back the other way saying, well, you know what, they're okay, but they're not any better than monophasic defibrillators, but since you already got rid of them, we'll just keep biphasics. We also got rid of the E-to-tube medications. They're through an IV, through an IO. IOs are not just for kids anymore. Oh no. You got a bone, we can drill you. I really have to rephrase that. Oh, it was that little voice. Don't do that, don't do that. Oh, we can't pull that. All right. But you also see early pacing. We proved that electricity is beneficial. And why delay something that's beneficial to your patients? More importantly, there were times in the earlier days when we would just say, holy crap, they came back, now what do we do? And now it's post-resuscitative care. Cooling them, protecting the brain, getting to a center that's going to continue that hypothermic therapy. Cool little tidbit I picked up when I was at our conference in Vegas for folks who use the nasal prongs oxygenation during intubation, so you don't have a drop in your O2 set. Leave the oxygen on and keep it at a high flush, because the cold oxygen blowing across the cribriform plate starts the cooling process of the brain. Just learn that. Pretty cool stuff. All right. Now the brain today, we give them some oxygen, we do the AccuCheck, we try to keep their glucose in a narrow range, we monitor them, look for a inciting rhythm that could flip the clock, throw an IV into them. Do your Cincinnati stroke scale. I actually taught about stroke out in Cincinnati, and I had to actually try to teach them the Los Angeles stroke scale. Wow, you talk about a hostile audience. But then I also had to tell them that Pennsylvania stole their stroke scale and said, you know, the sky is always blue in Pennsylvania. That's what we have in our protocols. So I was like, sorry. But you see more thrombolytic screening. You see that you're looking and you're aware of what some of the exclusion criteria are for thrombolysis in patients, and you're gathering that data. All right, and we realize that there's two other time-sensitive diseases other than trauma: MI and stroke. So we actually saw that Israel put some CAT scanners in their ambulances, and they were running around. Well, Israel's, you know, it's, what, smaller than New Jersey, but they split it. You know, northern Israel and southern Israel. And you get the data out there, you get the data sent back, so the receiving facility knows, I got a CAT scan coming back, I got somebody who's got a negative CAT scan, okay, let's get them in the pipeline. Well, guess what? It's not in Israel anymore. Germany has a truck rolling around. Arizona has a truck rolling around. There's a crazy urologist in Arizona that's doing data, riding out there and trying to say, we need to take a CAT scanner to everybody who's having a stroke. That's great. I get people coming in and I can't figure out if they're having a stroke. I just admit them for stroke-like symptoms. But I say, you know, early data is good. How do you effectively get it to them? So, but like I said, realizing that trauma care isn't just the only time-sensitive disease. Now, how many of you fly? Yeah? How many of you look at those rotors and look how close they are to the boulders? How many of you say, wow, there was like large brass ones clanging underneath that pile. All right, what do we see in the emergency department today, other than really good-looking people who get commercial breaks and have better sex lives than any of us? EMS today. We've got 5 books in just the Brady series. Each book is about yay thick. Not only do we have books that are thicker, but we have books that are being written by ex-providers. Brian Bledsoe is an ex-paramedic who's down in Texas, a member of the American College of Emergency Physicians, and he's writing books. We've added more didactic hours. We've added more clinical hours, more field hours. Now, these people are gone for a year. Kiss your loved one goodbye. They're ours. It's indentured servitude. We'll send them back out the other end. They get all the ABC courses. You get ACLS, PALS, DHTLS. You come out certified to intubate. Your national registry prepared when you come out the other end of a training program these days. Still need 80% to pass. Now, still being taught cool stuff though. But combi tubes and King LT airways. What do we say? Now, intubation is a skill that takes some psychomotor training. However, if you can find the mouth and keep them kind of in alignment, you can shove one of these things down their gullet and it will provide a decent airway for you. You have 12 lead EKG with interpretation and delivery to the receiving facilities. You have IO needles and guns and drills, and you know what? There's one that's a gun. I said it'll be really great, but you can't distribute that in a urban setting. Hold on, I'm going to put an IV in your loved one's sternum. No, that was like a 45. Put that. You have computer charting. Oh, we thought we were the only ones to have computer charting. We love computer charting, not. So, but you have it. Remember the good old days of sitting there, writing the chart? Oh no, I can't go back to service. I'm still writing my chart. I'm still writing my run report. Yep, it's a good run report. I don't run this on the street. So now you have computer charting. What you're also seeing is the realization that delivery of medication, especially over a longer time, needs to be controlled. Controlled much better than what we had. We have medication pumps now, syringe pumps. No more dial-a-flow. What's a dial-a-flow? We have dial that, supposed to be 60 drops of medicine. Close. There's something else to put in line between your IV bag and your patient. They worked sometimes. All right. Oh, sunrise on the south side of Chicago. I had to get out of the ER for something, and they were in for their coffee. Whether that or it was a holiday and they were just hiding from the bullets. Now, current research, look at what's coming down the pike with regard to airway management and video laryngoscopy. Playing with some of the new toys that are out there, they're in the range that makes them affordable. So you're seeing the King Visions come out there. You're seeing the Air Tracks. You're seeing video laryngoscopy because you can then electronically download your images to say, yes, tube went through the cords, documented at X time. Click, goes into your electronic medical record with your computer charting. How about ultrasound in the pre-hospital? We're starting to see that, not just for IVs anymore. What is it? Is it PEA, or is it just that they're so vascularly dilated that you're not going to mount any pressure, but you still have wall motion, significant wall motion, not that little. But if you got this pumping away and you got no pressure, guess what? Throw off the tank. Got the decision to field terminate, and it truly is. If you're going to do something, you're going to do it. Bringing me a corpse is not going to make them any less dead. If they were going to respond, they were going to respond to your care, not my care. Because dead is dead. We realize that. We're looking at research in cardiac arrest. Should a cardiac arrest, especially in a younger patient, you take the 78-year-old who drops over and has a cardiac arrest, guess what? They've had time to build collateral circulation for their cardiac disease. You get the 45-year-old who drops over from a cardiac arrest, they're too young to get the new vascularization and get the collateral flow going. So the 45-year-old may be benefited by bypassing the emergency department, leaving us in the dust and going right to the cath lab. There is some talk of looking at strokes and thinking about bypassing hospitals that don't have interventional radiology capabilities. I was down in Dade County, Florida, to talk to, they're looking at combining different stroke scale scores to decide, okay, if we do a Cincinnati and then we do an NIH stroke score and we get a number here, who can go to a primary stroke center, who needs to go to a comprehensive stroke center. So EMS is looking to do that. That's some of the research that's going on. Hershey was running a trial, and it's coming in phase 3 the last time I sent anybody out there. Very similar to an aortic balloon pump. It's just basically a balloon that sits below the renal arteries. It still allows a little bit of flow to the legs to keep the tissue receiving an adequate amount of oxygen. But what it does is shunts blood northward. So you put a semi-plug in that aorta low, and blood is preferentially going to go north because it's basically going to try to shunt blood to the ischemic penumbra. Again, we're starting to see more hypothermic therapy, and where is the goal range? And they're actually showing that 34 seem to have the better outcome than 32. The more data that comes back, the folks who went lower, 34 seems to have a better outcome. So if you're going to do anything, shoot for 34. And depending on your transport time and your receiving facility, you can adequately get people started in hypothermic therapy with just ice packs in the pits, groin, and neck, especially the neck. The carotid arteries preferentially dilate when they are cold. So if you can pack their neck, that's probably the best thing for them. Oxygen, high flush, start cooling the cruciform plate, start decreasing the temperature. All right, the new age guidelines came out 4 years ago. And what you see is also more integration of pre-hospital providers in general medical care. A few years ago when we started the flu clinic here in the region, how many medics went out there and gave flu shots? Yeah. And so we're saying, look, in a pandemic, here's this body of providers that do a very good job. And it's just like, okay, drive up, move on, drive up, move on. In a pandemic, we may be doing that. You're also seeing more national standardization. Why can I go to practice in another state? I got to get a state license, get through that, get through the hospital rigmarole to get on staff, but I can go practice anywhere. But it can be difficult going from one state to another because they don't look at training the same. So we're looking at standardizing the curriculum, bridging programs, so that because who can take a year out of their life? So every few years to do a training program. But also reciprocity between states. We already have strike teams here in the region, so this is not a research, this is not a trend. This is an actuality in the Eastern region. In the future, you're probably going to see antioxidants and free radical scavengers for cardiac arrest and stroke. Again, we're trying to protect the neural tissue. Can you imagine that? Giving half a milligram of epi, 50 milligrams of lidocaine, because we've learned that low dosing thing, and 20 of vitamin E. Yeah. So who knows? And here's a vitamin C tablet. Again, there are some other localized brain and cooling methods. One is kind of like a cap that cools them down, cools the scalp really well. There's a really demonic device that you shove in your nose. Do not use that with me if I'm unconscious. Anything in my nose? You know what? I like the current stretchers where you push a button that goes zzz. That's how I injured my back and got out of transport medic and I went into assist. But how about if they floated? Wouldn't that be cool? It's like, get on that. It's like a ride at Hershey Park. Right? Who knows? Maybe we can even retire bariatric ambulances in the future. All right, how many of you ask your patient's history and they say, any medical problems? Nope. Take any medications? Yep. What do you take? Blue pill, red pill, pink pill, white pill. Thank you.
But it's a little white pill.
It's a little white pill. Right. That's different than the big white pill, which is different than the little blue pill. But I can't remember it. All right, but here's the thing. As I teach in the classes, never ask them if they have any medical problems. They don't have a medical problem. You ask them their medications. If they do remember their names, you tell them why they take them. Oh, you take low pressure. You take that for blood pressure. Oh, you take microdose. You take that for diabetes. Oh, you take aspirin because you have a higher risk of stroke. And they go, yeah, how'd you know that? I'm psychic. Psychotic, yes. How about if you could just, like your puppies and kitties and horsies, where you can take them to the vet and they can scan them and they can tell you where you live, just put an implantable data chip. scan them, all the data is there. What do you think? Good idea? It's already been proposed. It was offered to me at an AOA conference probably about 10, 15 years ago. I said, nah. Linda knows where I'm at all the time. I don't need a data
What
sheet.
about just an SD card?
Well,
How cheap are they?
actually, that's what, there's a certain Eagle Scout that is putting demographics, health information, EKG, photograph, advanced directive, and a file for Con Ed on a water-resistant USB drive for tactical EMS and SWAT operators in the region. Just happens to be my son. That's his easy project. So it's doable. There are companies out there. How do you promote it?
We were doing it in the military.
Yeah.
We were doing it in the military back in '98.
I mean, you look at even the military, when folks who are on tanks, their information is in their boot because you're in a big incinerator, and they figure the information is there is going to burn into the bottom of the feet if your tank is incinerated. So we had ways of encrypting the data into the bodies in the past. All right. How about pulsimetry? You know what? You can get a lot of data if you get blood. Wouldn't it be better to get more data if you could just put that clip on? Now, folks learned a long time ago that I was kind of really helped to push along the carbon monoxide meters, co-oximetry, because bottom line, they're working on other things. Wouldn't it be nice to know what your patient's hemoglobin is? Well, when I first did this, guess what? It's here. You can get a hemoglobin level through a pulsimeter. You can get a carbon monoxide, carbon dioxide, oxygen saturation. You can get all that. How about if other things came down the pike so we didn't have to stick them for blood? How about if you got a glucose through that? Wouldn't that be great? Because the scope of practice is, there's your procedure, putting the probe on. The data you derive as an educated, intelligent provider, you take that information and apply it to your patient. So if their blood sugar from this is 120, you go, great, not my problem, move on. You get this, and go, ooh, SaO2, 88, problem found, fixed problem. Okay, so we derive, the data that is derived has to be interpreted by the educated provider. Would you like to get a little respect? Who knows? Maybe that's coming down the pike. Maybe. No, because you're actually being looked at. Okay, now, you got a lot of call volume, decreased reimbursement. You fight over territories because you'd like to have territories where everybody has insurance, right? But there's some areas that you'd like to avoid, you know, crack house alley, yeah, let's avoid that. Because you know you're not going to get reimbursed. Now, the IOM, the Institute of Medicine, is actually looking at, specifically has addressed EMS in the health plan. Now, the Institute of Medicine was created by that Democratic president from Illinois. What was his name? Or what is it there? He still has a name. What is it?
Lincoln.
Lincoln, correct. You were thinking something else? No way. Somebody who had good forethought. So the IOM was started by Lincoln. All right, but what they said was there's need to be more oversight by Health and Human Services. There needs to be regionalization of EMS because piecing it out is not efficient to deliver medical care to our patients, their constituents. National standards of training and credentialing. I said, make it easy because we are a mobile society. Why can't you go everywhere? ABEM, American Board of Emergency Medicine, recognized EMS as a subspecialty of emergency medicine. We did have a fellow from Lehigh Valley. Your fellowship is where you do extra training in specialty. She was up here for dinner tonight. One time. All right. More importantly, they're looking at a national health information communication and data system. Do we have a way to communicate data over a large area? Medcom. How about cellular networks? How about communicating data? Well, they estimate that 80% of the people, 60% of people, and possibly upwards of 80, but 60 is a pretty good solid number, have a chart somewhere, in the EPIC electronic medical record. Now, they may not all talk to each other, but there is an EPIC system that has somebody's name in it, and it's about 60% of the US population. They think it may be higher. All right, they also said that air medical needs more state oversight and more evidence-based medicine as to what we do in EMS. I mean, if you think about it, the data has been proven that for trauma care, you're better to be taken to a hospital by a BLS unit than by an ALS unit. So we need to prove that for ALS, our skills are valid to treat patients, but that didn't come out. How about disaster preparedness? Well, that's something we've done here. We've gone down to when they washed different areas, Sandy, Katrina, Gustav. More importantly, EMS research. Now, if you look at docs who are training in emergency medicine, have to do research, and maybe you get the ones that really have the spark and they can come and help and do EMS research, get you involved. Now, they said, we know you need money to do this. You can't do this for nothing. This is not an unfunded mandate. They said, we'll give you $88 million, but we'll disperse that over 5 years. How many states are there? Now, in 08, when they made this, they spent $339 billion on Medicaid alone. So, call volume, decreased reimbursement, fighting, legalization coming slowly, subspecialties here. We've got the way to get communication around, medical oversight's coming, evidence-based medicine, we talked about that, disaster preparedness. We have a lot of what the IOM said we need to do. EMS research is here, it's not a lot. And what they're giving us is $352,000 a year for each state. You know what? A first-year trial lawyer makes that much. One scummy shark makes that much. Trial lawyer. We can go back to trial lawyer. Okay, so what does it mean? People know we're out there. Okay, what you need to do is actually know who your representatives are, because the representatives who are out there, and they're here now. They're in your districts because the elections are coming up. They're not hiding in Washington. They're in your hometowns. Know who they are, and more importantly, be active with them and not say, I need this. Go introduce yourself and then say, hey, I do this. How can I help you? Because if they need a resource on what's happening in EMS in their area, who are they going to call? They're going to call the local hospital? You're in meetings most of the day now, right? So you may not be available. But hey, if you're one of the local constituents, you say, how can I help you? This is where I work. They call you. So it's not just those of us who have active AARP cards that go to talk to the legislators. Build a profession. You know, we can be our own worst enemy. Like I said, the IOM knows we're out there, but you want to tell them how you want to practice. Don't let them tell you how to practice. So, like I said, Al and I go way back. And the fun part is, we were getting in trouble back then. We get in trouble now.
Daily.
What are you talking about? But the whole goal is, the bottom line comes down, you do what's right for your patient. When something doesn't make sense, fight it. Know where to fight it, know who your legislators are, make your face known, make your voice known. You know, and like I said, don't go in and ask me for something, but go in and say, I do this, how can I help you? What can I offer to you? First off, you're going to throw them back on their heels because nobody ever goes in offering to help the legislators in the area. They all want something, fix the pothole in front of my house or whatever. So, talk to them. See, I put that in the last time too.